So we will have patients we know are indolent because they've been watched for 2 years. That's going to be my definition of truly indolent. And we'll have patients needed treating straight away. And we'll be able to compare with all this biological material we've got to find some kind of biomarker. That's the goal. The question then arises, and this is what I get asked not infrequently, is if you've got somebody, you've watched and waited them, and you've watched them for a couple of years, say, and then they need treatment, do you treat them any differently to somebody that presents in a more aggressive way? And you could argue that one of two ways. You could either say, well, biologically it's not behaving so aggressively, so then maybe you don't need to treat them so aggressively. Or your argument could be, if you treat them exactly the same way, you might get a better outcome. My approach is the latter, so I treat everybody the same at the point they need treatment. And one of the things I'm hoping we'll be able to pick out of this sort of population that we're going to follow is that we will look at outcomes of patients treated immediately with the standard treatments, CHOP, bendamustine, and see how durable they are. And then we'll look at the patients who were watched for a couple of years, who had indolent disease, and then we're treated exactly the same way and see whether their remission duration is longer, because that will help inform whether we need to do things differently. So I think one of the challenges is actually truly defining that group of patients, and then we can look at different treatment approaches.